All right, everybody, welcome back to Discussions with Dr. G, the only podcast that pairs neuroanatomy with a little sarcasm and the occasional cat reference. I'm Dr. G, and today we're rolling up our sleeves to dig into neuromuscular disorders and what actually happens when these brain to muscle signals get scrambled. So when we talk neuromuscular disorders, think cerebral palsy, multiple sclerosis, neuropathy, Parkinson's disease. We're really talking about damage to either the central nervous system or peripheral nerves. Basically, your body's electrical wiring has a short circuit. What does that mean for real people? Everything from weakness, tremors, spasticity, and pain to stuff like trouble seeing, swallowing, or just walking across the room without performing their own version of interpretive dance. Take cerebral palsy, for example. It's a non-progressive injury. That means it's not going to get worse over time, but it still makes daily life a challenge. Kids or adults with CP can have spasticity, sometimes dystonia, maybe seizures, and often trouble feeding themselves. Then there's MS, where your immune system gets a little overambitious and goes after the myelin in your CNS. Clients might have vision loss one day, bowel issues the next, and a heap of fatigue and mood swings thrown in for good measure. Neuropathy, that's more about the peripheral nerves. So lots of pain, numbness, maybe weird burning sensations, and don't forget the ever-popular foot ulcers if diabetes is involved. And of course, Parkinson's disease, or PD. I always say, if you want to see dopamine play hard to get, watch PD in action. Tremors, stiffness, slowness, falls, even problems swallowing. Cognition can take a hit too, which a lot of people forget. Not exactly the golden years anyone was promised, right? So yeah, both central and peripheral disruptions end up doing more than just slowing someone down physically. They can tangle up cognition, emotions, the ability to perform daily stuff, and really, it's all pretty brutal for independence. And that's my uplifting intro, but seriously, let's move on and talk about what, if anything, we can actually do for these clients, with some drugs, of course. All right, here's where pharmacology geeks like me get excited. Let's run the medication gauntlet. For Parkinson's, everyone and their grandma's neighbor has heard of carbidopa, levodopa. This dynamic duo basically works by getting dopamine, a chemical that's seriously lacking in PD, back into the brain. Of course there's a catch though, and it's going to be a big one. Timing. Timing is everything. Too early, too late, or God forbid you pair it with a steak dinner, think high protein meal, you're gonna have a bad time. There are also MAOIs like selagelene, which blocks MAOB, monoamine oxidase B, preventing dopamine breakdown and boosting its availability in the brain. This improves motor control in Parkinson's disease or mood in depression. Okay. For CP and MS, there are skeletal muscle relaxants, which come in two flavors. Centrally acting like baclofen, classic GABA B receptor agonists, squashing reflexes closer to the spinal cord, and peripherally acting like dantrolene. Dantrolene is the fire extinguisher for your muscles, blocking calcium so the muscle can't contract. That's huge for stuff like malignant hyperthermia too, but let's stick to the neuro stuff for today. Baclofen and dantrolene are your go-tos to reduce spasticity. You need to be careful if there's any liver trouble, and do not, I repeat, do not mix these with alcohol or any CNS depressant unless you want a nap that never ends. Now, if you ever see a kid with CP get way too calm after their baclofen pump gets adjusted, that's the drug turning down that spasticity dial maybe a little too much. It may have a little too much GABA in it. So they're going to spasm out and they're going to become very, very sleepy. MS has its own bag of tricks. Immunomodulators like interferon B or beta and glatiramer, which basically tell your immune system to chill the heck out. Then when things get bad, we bring in immunosuppressants. natalizumab and or metoxantrone. But those have really big risks, including infections. Now, on to the neurotoxins. Oh boy, my favorite. Botulinum toxin A, also known as Botox. We inject it so that it paralyzes just enough muscle to take the edge off of spasticity. But don't go picturing Real Housewives drama. We're talking about helping kids move, not wrinkle control. Then you have anticholinergics like trihexyphenidyl. They block acetylcholine so you get less rigidity and drooling, which is perfect for Parkinson's. Now, each drug has its own molecular trick, but the punchline is less muscle chaos, more function. Painful neuropathy? Let's use some membrane stabilizers like gabapentin or pregabalin, which can help, but again, the sedation is real, and you don't want to stack these with other sedating meds. And don't forget the adjuncts like antidepressants, anticholinergics, benzodiazepines like diazepam. Benzos are GABA boosters, so the more GABA you've got, the less motor neurons want to party. We use them for things like spasticity and CP and knocking out seizures or even calming the nerves at 2 a.m. So what are the most common mess-ups with all these drugs for MS and PD? Honestly, it's almost always timing errors, food medication interactions, abrupt stopping, or forgetting about underlying illnesses. For levodopa, those high-protein diets can block absorption. Immunomodulators, people forget about liver labs or the risk for catching every bug kindergartners come home with. What you've got to do as a nurse is anticipate. Think about the drug levels, organ function, and patient lifestyle before the patient has a crisis. It's not always sexy, but it keeps people safe. So, we've got a good grip on how the drugs work, but why give each one, and what should we absolutely avoid? Let's talk indications and the big red flags on every med card. Dopaminergic agents like carbidopa, levodopa. For PD, they're miracle grow for movement, but bump up that dose and bam, dyskinesia. Those weird involuntary movements that look like you're riding an invisible pogo stick? Yeah, that's dyskinesia. It can also cause confusion, hallucinations, and a blood pressure that does the limbo. With the MAOI, selagelene, you have to avoid abrupt discontinuation, and common side effects can include insomnia, dizziness, and nausea. Adverse effects include hypertensive crisis, which can happen if it's taken with tyramine-rich foods like aged cheese, cured meats, red wine, beer, chocolate. The list kind of goes on. It can also cause serotonin syndrome when it's taken with specific antidepressants like fluoxetine and sertraline, which are selective serotonin reuptake inhibitors or SSRIs. Teach clients to take these in the morning. Report severe headache or palpitations immediately, and avoid over-the-counter decongestants, herbal supplements, and of course, mixing them with SSRIs. Benzos, like diazepam, are basically the Swiss Army knife when you've got spasms or seizures, but trust me, they are absolutely not for babies under 6 months or anyone with myasthenia gravis. Now, side effects. CNS depression is the common theme, so think drowsy, unsteady, or in the worst case, breathing slows way down. Less than the minimum 12 breaths per minute. This is also known as respiratory depression. Combine that with opioids or alcohol, and you'll really see the box warning come to life, which as nurses, we never want. Baclofen. Sedation is the big one, while dantrolene can crank up those liver enzymes. So if your patient's eyes start looking a bit yellow, you know what to check. Withdrawal's a whole circus with these, baclofen in particular, because stopping it cold turkey can actually trigger seizures. Now, let's get into the immunomodulators, interferon beta, and the like. Absolutely life-saving for relapsing MS, but watch for low blood counts, liver issues, and if you're really unlucky, PML, which is basically a brain infection on nightmare mode. Don't give them to folks with active infections or bad livers. Same for the immunosuppressants. They're a nuclear option for MS that can tank your patient's white count or trash a perfectly good heart. So you'd better know their full health picture. Think flu-like symptoms, liver strain, lowered white blood cells, and a green light for every virus within a 100-mile radius. Last bit, membrane stabilizers like gabapentin or pregabalin. Besides the fun dizziness and swelling, they're also addictive for some clients. Antidepressants can be added on for neuropathic pain, like TCAs or tricyclic antidepressants. Don't use these if there is any history of glaucoma or heart problems. So, you see why careful assessment is non-negotiable? Okay. Anyway, these are all useful, but they'll knock you out, cause weight gain, or, on a rare but terrifying day, give you a full body rash or mess with your white blood cells. All right. So we've thrown a ton of drug names and warnings into the ring. What's the actual game plan for nurses? Monitoring. Never glamorous, always life-saving. You want to check for CNS depression, infection, anything weird with the liver or kidneys, and always keep an eye out for abrupt withdrawal symptoms. Fall risks? Don't even get me started, I swear. Our neuro floor could open up on a second career as stunt coordinators. Teaching. Teaching is huge. If you don't tell your patient to take their PD meds on time with the right food and not too much protein, you're going to see those tremors come back with vengeance. Same deal with antidepressants, especially the MAOIs. Oh, and one time I was warning a nurse about mixing Selagelene and some patients' cheese obsessions. Yeah, turns out aged cheese and MAOIs are really a brilliant mistake. You know who you are if you're listening. Anyway, you also want to tailor your teaching. Talk dosing schedules, how to manage dry mouth, and what to do if hallucinations crop up. Why avoiding CNS depressants is an absolute must, and why late-night Google diagnosing is never a substitute for good old nursing wisdom. Don't skip teaching pump care. The fewer ER visits for jammed baclofen pumps, the better. Am I right? It's all about consistency, monitoring, and teaching. Dopaminergic agonists need to be given at the same time. Skipping a dose isn't just oops, it's oops and now they can't move. For clients on these drugs, always ask about what they eat. Did grandma just serve them ribeye before their meds? Maybe let her know about those pesky protein interactions. The same with tyrosine-rich foods for anyone on an MAOI. Keep an eye on falls, especially in PD and MS. Immunosuppressants, flip into germaphobe mode. Hand hygiene, monitor temps, warn people about infection signs. Finally, be the medication bouncer. Check for interactions. Educate your clients on what not to combine, and please don't assume that your client knows a benzo isn't Tylenol. If they hear possible withdrawal syndrome, make sure they know that it's not just a catchy medical phrase, but a real thing. The job is to keep people safe and informed, even if it means explaining things with way too many bad analogies or using your cats as visual aids, which I do sometimes. The big picture here is that Pharm is a balancing act, relieving symptoms but keeping everyone safe. Nurses are the quarterback, the educator, the early warning system. And yes, half the job is making sense of drug names that sound like a Scrabble accident. Next time, we'll untangle even more Pharm quagmires and share a few more stories from the trenches. Until then, keep questioning, keep monitoring, and keep those cheese boards away from your MAOI patients.